So thanks, Anne-Marie, for the kind invitation. I'm delighted to be here today. So antiphospholipid syndrome, we're going from a very general talk by Dr. Kivan to a very specific talk. Hopefully I will clarify some things. And even amongst medical professionals, antiphospholipid syndrome is quite a kind of a complicated issue. So just from a basic thing, it's related to an overactive immune system. And this causes either blood clots in the veins or the arteries. So when I say arteries, I mean kind of heart attacks and strokes, or veins, I mean deep vein thrombosis or pulmonary emboli. So most clotting issues cause problems in one or the other, but antiphospholipid syndrome is different in that it can cause clotting in both. And then it can also cause pregnancy problems. So some people have problems with both issues, some people have problems with one, but in pregnancy it's generally a problem with the placenta. So you're more likely to have a miscarriage, you're more likely to lose a baby, you're more likely to have preeclampsia or have small babies. So if you think about it, the placenta is where the mom and the baby kind of merge together, and that's how the baby is fed. It gets all its nutrients, gets its oxygen. So if that's not working, it's problems for the baby. Most people are diagnosed between 20 and 50 years of age, but obviously that depends on what your medical team's kind of index of suspicion is. So if you don't look for it, you won't find it until later. It more commonly affects women than men, which is the same as almost all other autoimmune conditions, but still many people who have it are men. It can be associated with other autoimmune conditions, and I suppose lupus is one of the most common, and that's called secondary antiphospholipid syndrome, or you can just have antiphospholipid syndrome, and that's called primary APS. It's an acquired disorder, and that's really important because, as Dr. Kivan referred to previously, he talked about genetic issues and screening and looking for things. With antiphospholipid syndrome, because you can acquire it, we don't kind of suggest that you screen members of the family or things like that, because just because I say that your daughter doesn't have antibodies today or your son doesn't have antibodies, they still are your child and they still have your kind of genetic makeup, or at least half your genetic makeup, so they may still develop it. So that's why kind of family history is so key, and personal history and things like that, rather than tests, because a lot of the times tests give inappropriate worry or false reassurance. So I think context and patience and what's happening to you and your family is more important than anything else. We don't know why it occurs, okay? So this is something that crops up, and like many other immune systems, we don't know why. It's probably a mixture of a genetic predisposition and then some environmental trigger, whether that's infection or something like that, but it's not clear-cut and we don't know. And I say that having worked in an antiphospholipid syndrome centre in London for 3 years, I'm still none the wiser about why exactly all this happens. So it can affect almost any part of the body. So when we're kind of defining it or making the diagnosis, then we think about the blood clotting issues and the pregnancy issues. But there's many more areas that can affect. I suppose livedo reticularis is always one that we would think of doing antibodies if we saw this. So it's a very particular rash that you can get. Sometimes our vascular surgery colleagues will call us and go, oh, this clotting doesn't look right, or it's funny, or there's funny gangrene or things like that, like down here, and then we may consider it. So it's all about context. And again, it's all about, has something happened where your clinical picture doesn't really fit with this? So, you know, if you're a heavy smoker with high cholesterol and a strong family history and things like this happen, it's a little bit less unexpected. Whereas if you're young and fit, or a little bit less young but fit and clean living, and you don't have any risk factors, then we need to dig a little bit further. Leg ulcers are also much more problematic. And then you've got rarer problems like problems with your adrenal glands. So you can actually clot off your adrenal glands, called adrenal infarcts, or chorea, so you can get abnormal movements. These are all kind of a little bit more fine print in antiphospholipid syndrome, but they've all been well described. What everything is called is really confusing for patients, for doctors, for nurses, for everything. Everything is named in a way that doesn't make sense. So I suppose going from the top, when we're looking to make a diagnosis, we look at two different antibodies and one thing called a lupus anticoagulant. So a lupus anticoagulant sounds like it's a blood thinner, okay? It's not a blood thinner. But what it does is when we're doing clotting tests in the lab, it looks like you're on a blood thinner, okay? So the clotting time is longer. So it's not that you're kind of protected from blood clots, it's just, it looks the same as if you're on rivaroxaban or warfarin or anything. The clotting times are prolonged, and that's why it's called a lupus anticoagulant. But again, really badly named because it makes you clot. The lupus anticoagulant defines antiphospholipid syndrome, but it's not lupus. So you can have lupus without having a lupus anticoagulant and vice versa. So again, the name's there to confuse you. You can have persistent antiphospholipid antibodies and have no problem at all. Some people call that APL rather than APS. So rather than antiphospholipid syndrome, you don't have the clinical issues, but you have the persistent antibodies. But again, that's not very well defined either. And then sometimes in the literature, it's called Hughes syndrome. And that's because it was initially described by Graham Hughes in Guy's Hospital in London. There's a bust of him in the rheumatology department there still. And that's why, again, you're wondering, is this different? And then it's more commonly called APS now for antiphospholipid syndrome. Previously it was called APLS. So if you're looking things up about it or anything, these all mean the same thing, but lupus is different. So you can imagine just how you can get caught up in reading the wrong thing or looking at the wrong thing. You're thinking you have the same problem as someone else when actually you have quite different problems. So the confusion is really not helpful. This is a very long slide. You don't need to read it. Every so often there's a meeting. So first there was the Sapora criteria. The ones we use most recently are the Miakis criteria. So basically what we're saying then is if we're making a diagnosis of antiphospholipid syndrome, you have to have a clinical problem. So that's either you have to have had a blood clot or a stroke or a heart attack, and then you have to have a laboratory issue. So you must have persistently positive antibodies. And why we say persistently positive is that anybody can have antibodies positive once and it probably doesn't mean anything, especially if you have an infection, if you've gotten a vaccine, if you've had anything that stirs up your immune system. So you must have antibodies positive on 2 occasions, 12 weeks apart, that's the persistent, and they need to have been positive within 5 years of the clinical issue happening. Okay. Does that make sense? Again, I mentioned incidental antiphospholipid antibodies. So with healthy individuals, 1 to 5% people have a lupus anticoagulant and it never causes them any problems. Similar percentages for anticardiolipin antibodies and anti-beta-2 glycoprotein antibodies. So I think this all demonstrates our lack of understanding of the condition. We're kind of measuring it with very coarse tools at the moment and trying to put the story together. But kind of a clue in the name is that if something says syndrome, we don't fully understand it, okay? As you have more problems, you're much more likely to have positive antibody testing. But healthy people can have these antibodies, and that's why we don't really like screening people, because once you screen somebody and you have something, and we can't tell you if you're going to develop a problem or not, we're causing problems for you if you're filling out an insurance form or anything like that. We can't say that you're at a higher propensity for a clot or not, but certainly we have an objective test that says there's something there. So we do like to test for a reason if we're going to change your management. We're not going to do anything in particular if you're a healthy individual and have antibodies. I suppose this is probably the most important slide. So I couldn't find a woman with no features, but what it is it's the importance of having the patient themselves and all their clinical characteristics and their family history and their context, plus the antibody, and then we think about their risk, okay? Either or is not as good. This is actually the most important thing, the patient themselves, for defining risk. Antibodies add to it, but who you are, what's happened to you. And I always say this, that if you're someone who's had 5 clots when you're 20, then I don't care what tests show, you have a problem with blood clotting, okay? And if you have 20 sets of tests and everything looks perfect, you've already demonstrated that you have a problem with clotting. And then the other is true as well, that you can have loads of abnormal tests and never have a problem. So it's the person is the most important thing when we're thinking about risk. So when we're managing antiphospholipid syndrome, what we want to do is think about the patient-related risk factors And then can we do anything to the APS itself? So you can change your genetics and you can change your family history. Why I put them, they're kind of the same thing, but we don't know everything about the genetics. Okay, we look at a very small kind of area on the genome, so there's loads of things we don't know about and we don't investigate. You know your family tree. If everyone has had clots in the family, or everyone has had pregnancy problems and things like that, then there's probably something in the family. And just because we don't have a test saying that there's nothing, if it's all shown there, then that's a problem. But we can't change that. So we should acknowledge it, put it down as a risk, and then kind of go, well, we can't change your genetics, we can't change your family. So look at other things. There's loads of modifiable risk factors, and I suppose I put modifiable there in a kind of inverted commas because you can say you can modify them because technically you can, but they can be quite difficult to modify. So I suppose sugar, managing diabetes, managing your weight, stopping smoking, keeping active, managing blood pressure, getting plenty of vitamin D in your diet. These are all things that technically can be managed, but it can be a lot easier doing it than saying it, but it is worth doing it. Everything with clotting is kind of incremental risk. People like to have kind of this one thing that I got my clot because, but generally it's I got my clot because of my genetics and the situation and something else. It's an additive thing rather than just one thing. So I think it is worth trying to improve things. So every cigarette makes your blood a bit stickier. If you're smoking 40, it's certainly better to be smoking none, but it's also better to be smoking 39 than 40. So, you know, incremental things mean something, and it is worth trying. Even if you can't kind of resolve everything, it's worth trying to get things to be a bit better. I put that first because I think it's probably more important than the medications, the whole setting of you as a person. As I said, if you can fix you, we can't really do that much about the antibodies. So thinking about that is equally important. So depending on what's happened, so if you have pregnancy problems, generally a lot of your problems are only manifest if you're pregnant. So if you're not pregnant, it's less of an issue. But if you are pregnant, then we need to think about things to look after the placenta. So the two big things we look at are aspirin, which has been shown to reduce your risk of preeclampsia, and low molecular weight heparin, which is the blood thinner we use in pregnancy because it doesn't cross the placenta. So the mom gets the anti-clotting effect, but the baby doesn't get anything, and it doesn't cause any fetal abnormalities. So you get the benefit of that anti-clotting effect, but you don't have any of the pregnancy problems. Hydroxychloroquine, I think is there somewhere. That's also commonly used in antiphospholipid syndrome and lupus. It's safe in pregnancy, and what we think it does, it kind of modulates the immune response, so it seems to dampen down the antibody effect a little bit and can be beneficial in pregnancy or in clotting. And the rheumatologists use it very commonly in lupus. And then warfarin is your anticoagulant of choice in antiphospholipid syndrome. I'll go into that a little bit further in the next few slides. Statins and vitamin D supplementation have also been shown to be effective. So in big studies, we know that people with vitamin D deficiency are more likely to have another clot than people who have good levels of vitamin D, and people on statins are less likely to have another clot than people who are not. Okay, so that's not in really kind of high-level randomized controlled studies. It's more looking at kind of population-based data. So first line for anticoagulation, as I said, is warfarin. However, it's quite hard if you have a patient who has been on a DOAC for years, which is what we used to have in London, and then suddenly you're trying to switch them. Because as a lady previously responded, that if you're well established on a DOAC, rivaroxaban, apixaban, dabigatran, your life is probably much easier than it is if going to warfarin. So going to warfarin is a huge lifestyle change. So we have to kind of justify that and explain that to you. Usually what we're looking for with warfarin is an INR target between 2 and 3. Okay, previously it was a higher one, but for most people it's between 2 and 3 now. So the first time we started using the new agents in antiphospholipid syndrome was after the publication of the RAPS study. So you don't really need to know the details of it, but this is people who had blood clots in their veins before, so pulmonary emboli or deep vein thrombosis, and they were on warfarin, aiming for a target of 2 to 3. And they wouldn't ever have had another clot on warfarin. So we would consider these people to kind of the lower risk antiphospholipid syndrome, so the people who were managed with standard anticoagulation. And some people went on warfarin and some people switched to rivaroxaban. And there was no real difference within these populations. So we used to recruit for that trial, and so we had loads of people with antiphospholipid syndrome on rivaroxaban. Wonderful. Then there was lots of publications that came out. Okay, so 2 of them from our centre. So people who'd had really damaging clots on switching from warfarin to rivaroxaban. So not everyone, but some people. This lady certainly had catastrophic antiphospholipid syndrome, so clotting in multiple systems at the same time. She'd been really well maintained on warfarin, and the only reason she changed was convenience, and that was a perfectly reasonable thing to do. Warfarin is a big kind of investment in your life and in time, and some people really find it hard to keep a therapeutic range, so it would have been very reasonable, and based on the evidence at the time, that's what many people do. But we started to think that maybe all clots weren't the same, and maybe all blood thinners weren't the same. So then an Italian group published this study. It's called the TRAP study. And this was similar to the last one. It looked at warfarin versus rivaroxaban. But this time, they looked at people with triple positive antibodies. So we looked for 3 different antibodies. But in the first one, they were kind of one antibody was positive. These had all of them had the 3 antibodies positive. And they were allowing people with strokes and heart attacks. So we would consider these the really high risk antiphospholipid syndrome people, okay? And they were switched to the same things as the RAPS trial. And this was very different. So this got stopped early by the safety monitor because 12% of people had a recurrent thrombotic event and there was a death, okay? And this is why we're very jumpy about it, okay? And this is why sometimes if people are very well controlled on warfarin, there's kind of going, should we change if they're well controlled? I'm not saying we shouldn't change for you, but it's just, there is kind of some method behind the madness. Following that study, the European Medicines Agency kind of put a ban on the oral anticoagulants other than warfarin. So even though it was just rivaroxaban in the trial, they named all of them and said you shouldn't use them, okay? So it is quite hard to prescribe them in the setting of that ban, okay? So what the British Society of Haematology would suggest is that have a discussion with your patient. And as we've said before, it's all about kind of, you know, the clinical context plus the patient plus wishes and beliefs and things like that. But to explain that that is the risk and that's why we're considering warfarin and not just because we want to be awkward and things like that. If you've had a stroke or a heart attack, the evidence is kind of less good in that there's less published studies on it. Most people go that if you were young or if you've got multiple antibodies, then warfarin is probably your anticoagulant of choice. But depending on what your other risk factors are, I suppose when I say that, if you've got really horrible carotids and you've had a stroke, then we know that atherosclerosis disease is probably an issue, and aspirin probably plays quite a big role. And the stroke physicians might say actually aspirin and clopidogrel or something like that is what you need versus warfarin, that they don't think it's a primary APS thing. But it's a harder balance. But these are the things that need to be considered. But again, they underlie that modifiable risk factors. That's your sugars, your cholesterol, the smoking, the blood pressure, the activities, all need to be monitored in parallel. Again, a very busy slide, but just our other things after the blood thinners. So vitamin D, hydroxychloroquine and statin are the next ones that are most commonly used in this setting. If things are going wrong on kind of standard warfarin, then most people will have a trial of low molecular weight heparin, so Clexane, Inahep, something like that. Maybe at higher doses, they may push up the warfarin. For some people, if they're being monitored on a self-testing machine and they have antiphospholipid syndrome, it may not be monitoring them accurately. So it's really important that if you're on warfarin and things aren't going right, that they have a venous test. So a venous test is when they stick a needle into the vein and they send the sample off to the hospital laboratory, because the lupus anticoagulant that I talked about before, that can interfere with the INR monitoring. So if things aren't going the way they should be, but the INR numbers look okay, then we probably need to have a look at that in the hospital. Because depending on how we measure INRs in the hospital and in the monitors, it can affect things differently. So we certainly have some people that we need to do a different methodology for measuring INRs if they have antiphospholipid syndrome. So this lupus anticoagulant keeps on sticking its head up and complicating things, but it's really important to know that we're giving you the anticoagulation that we think we're giving you. Again, just a little focus on pregnancy again. So if you have antiphospholipid syndrome, your pregnancy is high risk, okay? Not that you shouldn't do it, but just it's high risk. You need a little bit more love and attention during the pregnancy. Aspirin improves the live birth rate, okay? So that's great. That's very easy, very straightforward, very uncontroversial. Other than that, if you've had a clot before, it's also very easy. You go on aspirin and low molecular weight heparin and no one really thinks about it. It's the people with the antibodies and the pregnancy loss are a little bit more complicated. Should you just be on aspirin? Should you be on low molecular weight heparin? And generally what we'll do is we'll look at thrombosis risks in general and see where you fit, and also look at your bleeding risks. Because what we don't want you to do is to kind of put you on a drug that makes things worse, okay? But we do know that both those medications are very safe in pregnancy. It's really important to note that the two leading direct maternal causes of death in Ireland are thrombosis and preeclampsia. So antiphospholipid syndrome fits right in with this. So we're really wary about it. And we think about it all the time. And I'm currently the chair of the writing committee for the National Obstetric VTE Guideline. And this is one of the issues that comes up again and again. Right now. I have lost, no, hold on. I have lost something. Oh, thank you, Anne-Marie. This is a little bit my soapbox, so women's health in general, because I think sometimes people can be a bit dismissive. They go, oh, you have a clotting problem, we can't do anything with you, you can't have anything really, and that's actually not true. So it's just about a little bit of thinking. So certainly contraception. The combined oral contraceptive pill will increase your risk of thrombosis, and that will increase everybody's risk of thrombosis who takes it. The important thing is what's your baseline, so what's your genetics, what's your individual risk, because the pill can push you up. We know that factor V Leiden and the pill are very bad bedfellows and really push up your thrombosis risk. However, we also know from a lot of trials that if you're on full dose anticoagulation, then actually the pill doesn't increase your risk of recurrence. Okay, so we need to think about that. In the same way that if you're pregnant and you have a clot, we don't go, oh, we must end the pregnancy to reduce your clotting risk. No, we just move your medications around it and give you a safe. So we can do that. And I think that's really important, because certainly if you started the pill because you've really bad periods and then you got a clot, and then suddenly we're like, we're taking away your pill and we're going to put you on a horrible blood thinner, and now your periods are going to be awful. And no one will want to talk about it, and we'll all pretend it's not happening, but actually it does. And if you ask people, they're very upset. So again, periods are really important. Pregnancy, it's just high risk and we need to look after you. And again, Dr. Kivan brought this up, hormone replacement therapy. It's all fine to say, oh, we won't give you anything and you can just suck up the menopause and you'll be fine. But actually, what we know is that transdermal, or the patches, don't have an increased risk of thrombosis. So we should be looking after these women who already have a high, kind of a chronic condition, and we shouldn't be going, actually you have your chronic condition and you can have the menopause as well without any treatment. You're welcome. So there is ways to work around things. Some colleagues in Trinity are doing some research on women and periods. So this is just a little shout out in the middle of it, just to try and kind of get more evidence going. This is not really one to read, but these are kind of ongoing trials about antiphospholipid syndrome, just to kind of give anybody with APS a little bit of confidence that we are trying to build on the evidence and look about things. Astra APS and RISAPS, so they're the two DOAC APS trials. So we haven't given up on DOACs and APS, we just think we might need a different dose, or we might need to manage it differently. So people are looking at things. There's a couple, a lot of work on hydroxychloroquine in pregnancy, and then other antibodies and things like that. So hopefully watch this space and things will improve. So I'm going to leave it there, but happy to take any questions.
Visit thrombosis.ie. Spot the signs, save a life.